Uh, Good morning, good afternoon, and good evening to all the participants and panelists for this yet another ACNS YNS education program, especially for the young neurosurgeons and especially for the young neurosurgeons from the low resource countries. So today on 10th April, we have this another session of education where we have Professor Ferris Gerard Neto with us as our guest speaker and Dr. Sebastian Liao as one of the young neurosurgeon speaker. And for this, we have Professor Yoko Kato, our chief patron, and along with that, three chairperson, Professor Arion, who's also a student and fellow of Professor Yoko Kato from Fujita Health University. And recently, he's at the Barrow Neurosurgical Institute at Phoenix Children's Hospital, Phoenix. And Professor Fawad Pirzad, who's the president of Neurosurgical Society of Afghanistan, and Professor Ibrahim, who's the president of Association of Neurosurgeons in Bosnia and Herzegovina. And with that, I have my co-moderator, Dr. Liu Gun Singh, and Dr. E from Myanmar to moderate with me. So with that, may I request Professor Yoko Kato to kindly say a few words before we start the webinar, please.
Thanks so much. So I'm very happy to receive so many important persons as a chair, as a discussant, as speakers, especially Dr. Ferris is one of my good friends and also teacher, especially the ABM and the anatomy. And also the Wint from Myanmar. She is a very brave lady, as far as I know. So I think we should have a very nice the webinar today, I think. Thank you very much, Sachin.
Thank you. So may I request Professor Arion to say a few words before we start the webinar?
It will be just my pleasure to share here the screen and have the honor to introduce Dr. Ferris with us. Now, is this screen showing okay for you? Can you see me right?
Yes. Yes.
So perfect. That's so perfect. Dr. Ferris, good morning there in Sao Paulo for you, and thank you very much for joining us. It truly gives me an honor to have the opportunity to introduce you with the rest of colleagues. And before I move on with the list of introductions, I wanted to thank everybody that's joining us. My thanks especially go to Dr. Pirzad. I need to mention that he's joining us from Afghanistan, and I very much wish that things are settling down and getting to a more peaceful life going on there for colleagues and everyone in the country. Now, moving forward, I have my pleasure to introduce one of the most renowned vascular surgeons in the world, Dr. Ferris Eduardo Aparecido Chado Neto, who graduated from the Pontifical Catholic University of Campinas in 1996. He attended there his residency in neurosurgery as well, and that was followed by a fellowship in vascular and tumor microsurgery, that in 2001. Dr. Ferris is very passionate in neurology and neurosurgery. He then moved on to graduate studies and completed both master's thesis and PhD at the State University of Campinas at Unicamp 2006 and 2010. Moving forward, Dr. Ferris is one of those lucky students who in his life had the pleasure to study and work under the mentorship of Dr. Roten in Gainesville, Florida. He there attended fellowship in microsurgery anatomy, continued afterwards with a postdoctorate again in neurology at the University of Sao Paulo. And it is there now where Dr. Ferris currently executes many functions, and he is attending his practice as an associate professor in neurosurgery. He heads and chairs several divisions within that, but the main aim of Dr. Ferris rests in teaching fellows and students in the anatomy in general of central nervous system, but more particularly that of the cerebral vascular neurosurgery of tumor neurosurgery on skull base. And although we have been distant and apart from each other, I had the pleasure to pull out some pictures when I saw who was attending. So I very much thought of having a moment of friendship and mentors. If anybody here can see who I have, it gives me a great pleasure to come together with Abida, my friend from India. Ibrahim, if you can hear me, you are there somewhere, you can see your face back then in Salzburg. And of course, I would like to have here Professor Kader as my favorite mentor throughout these years of training and education. With all that, I hand on that to Dr. Ferris. And once again, Dr. Ferris, thank you so very much for joining us.
Thank you so much for the invitation. Thank you, Dr. Kato. Dr. Kato is a great inspiration for me. I have a new book now. Dr. Kato wrote the foreword. I am very happy to participate in this event. I hope to contribute to you. Okay, can I share my screen? Where is my, just a moment. That's okay? That's okay?
Yes, Professor.
I am to speak about AVM surgery. I love AVM. Yeah, I would like an anatomical point of view. This is my hospital where I perform most of my surgeries. I work in the university, the Federal University of São Paulo, Unifesp, and the Hospital Beneficência Portuguesa de São Paulo. This is my team. I am a head professor and chief of vascular neurosurgery in the Federal University of São Paulo. This is my book, Microanatomy and Surgery. And this is my lab of microneuroanatomy and at Unifesp. There, medical students, residents, and fellow are their anatomy and microsurgical skills on placenta and cadavers. I want to urge you to practice, and practice. Just a moment. The lab has 21 stations with injected heads, brains, cavernal signs, brainstem. You are all welcome to visit whenever you have the chance of traveling to Brazil. I have a fellowship program in vascular neurosurgery. I have fellows from a lot of parts of the world. We are all welcome to visit. What's the definition of the AVM? The AVM is a tangle of abnormal vessels between arteries and vein without the capillaries. What characterizes the AVMs is an early drainage vein. The AVM has arterialized vein. The veins is the most important anatomic landmark to localize the AVM. This is a vein of the AVM. This is a normal vein. It's a completely different, but I needed to know anatomy to identify in the surgery. The difference between the arterialized vein and the normal vein. Here, in this picture, we can see the frontal horn and the anterior view. In this anatomical specimen, can also to appreciate all the sulci point to the lateral ventricle. It's a very important landmark, which is very important to take on account in the study of the AVMs. They also tend to point towards to the lateral ventricle. There are a lot of shapes of the AVM. The shape depends on where it's located in the brain. The AVM can be seen as a circular, square, or cone-shaped. The cone is the most common because the most AVM originates from the sulcus and the gyrus of the lateral surface. We can see in your mind the lateral sulci, the sulci of the lateral surface and the inferior surface of the brain point to the lateral ventricle. It's a very important landmark. What do I need to plan and operate on AVMs? The neurosurgeon needs ability, dedication, art, technique, training, and anatomical knowledge. We should study the MRI and the angiogram to localize the AVM and understand the relationship between supplying arteries, drainage vein, and the nidus. I consider the T2 to be the most important sequence as it allows you to visualize the location of the AVM in the parenchyma when studying the preoperative digital subtraction angiography. Remember, an AVM is defined by the filling of the draining vein and the arterial phase. The early arterial phase of the angiogram is a key to identifying the number and position of the feeders. The intermediate arteries phase define the drainage vein in this case. The first step to operate AVM is go to the lab. Why lab is important? So it's possible to learn anatomy and the development of the neurosurgery techniques. When we study the hemisphere in the brain, we have a three surface: the lateral surface, the inferior surface, the middle surface. The lateral surface, why identify the sulci and the gyrus in the lateral surface? The frontal lobe, the parietal lobe, the temporal lobe, the occipital lobe. I need to identify the connection between the vertical sulcus here and the horizontal sulcus. When you see the connection between the vertical sulcus and the horizontal sulcus, the vertical sulcus is the precentral sulcus or the postcentral sulcus, never the central sulcus. We can see here, if it's the precentral sulcus, the vertical sulcus, connection with the horizontal sulcus, this is a precentral sulcus or the postcentral sulcus. Here, if it is a precentral sulcus, precentral gyrus, central sulcus, postcentral gyrus, postcentral sulcus, supramarginal gyrus. It's a very important anatomical landmarks. Oh, in the frontal lobe, we can see the one vertical gyrus, the precentral gyrus, and the three horizontal gyrus, superior, middle, and inferior frontal gyra. It's a very important for us. It's a very important. Here is this, okay, I can identify the vertical sulcus, the connection between the vertical sulcus and the horizontal sulcus. This is a precentral sulcus, precentral gyrus, central sulcus, postcentral gyrus, postcentral sulcus, intraparietal sulcus. Why is the connection between the vertical sulcus and the horizontal sulcus? The vertical sulcus is the precentral sulcus or the postcentral sulcus, never the central sulcus. Here is the postcentral sulcus, postcentral gyrus, central sulcus, precentral gyrus, precentral sulcus. If it's the intraparietal sulcus, superiorly, we can see the superior parietal lobule and the inferior parietal lobule. But the inferior parietal lobule is formed by supramarginal gyrus and the angular gyrus. How I identify, for example, the supramarginal gyrus? The supramarginal gyrus is located posteriorly to the postcentral gyrus. The supramarginal gyrus is the end, is located the end of the Sylvian fissure. Okay, the end of the Sylvian fissure. The parenchyma located in this position is the supramarginal gyrus. The supramarginal gyrus is continuous with the superior temporal gyrus. The superior temporal gyrus is continuous with the supramarginal gyrus. So it's a very important landmark we can apply in the CT scan, the MRI, in my surgery. It's very important for in this MRI, for example. Here, in the vertical sulcus, the connection between the vertical sulcus and the horizontal sulcus. The vertical sulcus is precentral sulcus, precentral gyrus, central sulcus, postcentral gyrus, postcentral sulcus. Here is the superior frontal sulcus, is the interhemispheric fissure, is the superior frontal gyrus, is the middle frontal gyrus. The superior frontal sulcus point to the hands area. Is a very important landmark for us. The anatomical landmark, not the function landmarks, the anatomical landmarks. The superior frontal sulcus point to the hands area in the precentral gyrus. Here, where is located this pathology? Here, the connection between the vertical sulcus and the horizontal sulcus. The vertical sulcus is the precentral sulcus or postcentral sulcus. Here, precentral sulcus, precentral gyrus, central sulcus, postcentral gyrus, postcentral sulcus, intraparietal sulcus, superior frontal parietal lobe, inferior parietal lobe. Where is location this AVM? In the precentral sulcus and the precentral gyrus and the central sulcus. Here, precentral sulcus, superior frontal gyrus, middle frontal gyrus, precentral gyrus, central sulcus, postcentral gyrus, postcentral sulcus, intraparietal sulcus. It's a very important landmark. The same in the MRI. The connection between the vertical sulcus and the horizontal sulcus, precentral gyrus, central sulcus, postcentral gyrus, postcentral sulcus. It's applying the anatomy in the CT scan, MRI, and my surgery. Here, the precentral sulcus, the connection of postcentral sulcus, the intraparietal sulcus, postcentral sulcus, postcentral gyrus, central sulcus, precentral gyrus, precentral sulcus, superior frontal sulcus. Where is this AVM? This AVM is located in the posterior part of the precentral gyrus and the central sulcus. Why? The other point is the insula. Where is the insula? The insula lobe is located in the inside the deepest part of the Sylvian fissure. But why? How I identify the insula lobe? I needed to identify the anterior and posterior Sylvian points. Here, where is the anterior Sylvian point? The main trunk of the Sylvian fissure in the anterior Sylvian point divide the anterior, superior, and the posterior rami of the Sylvian fissure. This point, the apex of the pars triangularis, define the pars orbitalis, pars triangularis, and pars opercularis of the inferior frontal gyrus. And the apex of the pars triangularis point to the Limen Insula. The Limen Insula is very important landmark for us. And because it's the place where the middle cerebral artery turn M1 turn to M2. And the posterior, if the anterior Sylvian point is the Limen Insula, the posterior Sylvian point is the Herschel gyrus. Herschel gyrus is a very important landmark. Why? It's because this point is marked with the end of the insula. The Herschel gyrus point to atrium of the lateral ventricle. divide the sylvian fissure in two parts, the anterior part, temporal pole, the posterior part, temporal plane. Is more difficult to open in the surgery. Oh, okay, where is the insula? The insula is located between the anterior and posterior sylvian points. What is observed in the surgery? The surgery, the middle cerebral artery, the M1 goes from bifurcation of the internal carotid artery to the insula, the linear insula. Because in the linear insula, the middle cerebral artery turns to posteriorly. Oh, but how identify in my surgery? Here, the middle, from middle to lateral, M1, from anterior to posterior, M2. M1 goes from medial to lateral. M2 goes from anterior to posterior. M3 goes from medial to lateral. And M4 goes from inferior to superior and the superior to inferior, spread in the lateral surface of the brain. How identify the limb insula in my surgery? Identifying the limb insula where the middle cerebral artery, the M1 turns to M2. This point is the limb insula. Identify my surgery because the M1 turns to where the point where the middle cerebral, the M1 turns to M2. This point is the limb insula. We can see the M2 goes from anterior to posterior, M3 goes from medial to lateral, and the M4 goes from superior to inferior and inferior to superior. Here, inferior to superior, to frontal and parietal lobe, to superior to inferior is the temporal lobe, the anterior sylvian point, and the anatomy relation with the ventricle is this. I can see the ventricle, the thalamus is the head of the brainstem. The lateral ventricle surrounds the thalamus. Anterior to the thalamus, frontal horn. Superior to the thalamus, body of the lateral ventricle. Posterior to the thalamus, atrium and posterior horn. Inferior to the thalamus, temporal horn. If I have thalamus, I have fornix. If I have thalamus and fornix, I have choroidal fissure and choroidal plexus. So when I can see the plexus located superior to the thalamus, where I am in the body of the lateral ventricle. When the choroidal plexus located behind the thalamus, where I am in the atrium. And under to the below to the thalamus, where I am in the temporal horn. So, what the gyros of the lateral surface correspond to the ventricle? The pars triangularis and pars opercularis correspond to the frontal horn. The precentral, the inferior part of the precentral and postcentral gyros correspond to the body of the lateral ventricle. The atrium correspond, the supramarginal gyros correspond to the atrium. And the middle temporal gyros correspond to the temporal horn. And the spaces, I have some corridors, natural corridors in my brain. I need to use this anatomy and the ability. We have a space, supraoptic, optic carotid, carotid oculomotor, free border of tentorium. But what's the position of the internal carotid artery? The internal carotid artery is located inferior lateral to the optic nerve. The third nerve is located inferior lateral to the internal carotid artery. And the free border of tentorium is located inferior lateral to the third nerve. The posterior cerebral artery passes above the third nerve. The superior cerebral artery passes below the third nerve, and the anterior part of the ankles is located lateral to the internal carotid artery, and the middle cerebral artery passes above the posterior part of the posterior portion of the anterior part of the ankles, because we divide the ankles in three parts: anterior apex and posterior. The anterior cover the amygdala, the posterior cover the head of the hippocampus. This is the anatomy. This is the anterior part of the uncus. Yeah, why is the anterior part of the uncus? Because it's located lateral to the internal carotid artery. It's anatomy. It's anatomy. And the superior, the middle cerebral artery pass superior to the anterior part of the uncus. I have two landmarks: the internal carotid artery located medial to the anterior part of the uncus, and middle cerebral artery, because the uncus is located below the middle cerebral arteries. In the lab, from the lab to the OR, I speak about the lab because I stay in the lab all the time. I stay in the lab all the time, my career. I know to prepare the pieces, the head, the brain. And lab is important to acquire manual skill and dexterity before operate a complex device like AVM. A simple or complex device. You need to go because you need to pay attention in my hand. My hand to need to rest on the craniotomy, because the craniotomy is very important. The head position allows us increase to venous outflow and reduce the cerebral edema. It's okay. But the position and the craniotomy is very, very important. It's a landmark, a technique. Why is the technique? The craniotomy for AVM, for examples, if you ask for other neurosurgery, the craniotomy needs to sufficiently wide. We need to expose the AVM and the normal brain with the landmarks. It's okay. But for us, the craniotomy is very important. I have some published about pteronal, pretemporal auxiliary. Okay, but for us, the head position and the craniotomy is very important. Why? It's the position of my hand. My hand rests all the time on the bone. On the bone is for me the most important in surgery. Where is the rest of my hand? Because my surgery, I don't know if I perform my surgery 1 hour, 2, 3, 4, 5, 6, 15 hours, 20 hours. Because the craniotomy is very important. Because you rest for me, rest of my hands. It's different. In the lab, we can simulate a surgical table with the instruments. That's okay. The instruments adapt to my hands and not the hands to the instruments. The length of the instruments, my hand is the same position all the time. It's very important. You are training the lab. You position of your hand. My hand rests on the craniotomy all the time. I have a lot of types of length of the instrument, scissor, knife, bipolar. Here, you need to have a lot of length. Our instruments can be our ally or enemy to battle against the AVM. Okay? I recommend having more than one bipolar force and different size. Okay? And the craniotomy needs to be sufficiently wide to expose the AVM, the normal, okay, and brain with the landmarks. The arachnoid dissection, here in the lab, the placenta is an excellent training tool for vessels and arachnoid dissection. It's the same. It's the same, simulate very well the vessels and the arachnoids with their membranes. It's important to keep the dissection in the arachnoid plan. If you lose this plan, you might end in the nidus and provoke bleeding. If bleeding will occupy the subarachnoid and subpial space, you'll be unable to see the anatomical landmarks. if this happens. It's a very important, the landmarks and techniques. Here we can see the AVM completely demarked after the initial arachnoid dissection. And then we can go forward the skeletonization of the vessels and coagulation here. We can see the arterial vessels completely skeletonized. Facilitate the identification of the branches going to the AVM to then safely coagulation and cut it. We repeat the same procedure. Surround the needles until all the feeders are coagulated. It's the same, it's the technique, it's the lab. The lab is not anatomy only, it's the technique, position of your hand. How I get the instruments in my hand. I need to training, practice all the time. Look. For operating this AVM, I need to know about the anatomy and techniques. Okay, I know about the tumor or the biology, but when I am going to operate, my hand shake. I can't, I am a neurosurgeon. I needed to go to the lab to get a scissor, get a knife, a combine. I use my two hands, but my both hands, all the time. I spend a lot of hours to dissect the arachnoid. I needed to know about the anatomy, where I am. It's the eloquent area. It's not eloquent area. For me, AVM is different pathology because it's congenital for me. But if the vessels end in the AVM, for me, is not eloquent area. If the AVM has a vessels in passage, it's an eloquent area. So I am dissected. I am very fast. I mean, it's I pass more fast. So it's a lab. When I'm going to, I go to perform a bypass, some surgeries. I go to the lab before the surgery, prepare my hands. When I am operating, I am dissecting a lot. Why? Because I'm preparing my hands. Principles the surgery is the good for the AVM. At the end of the procedure, the difference color between the arteries and the vein is clear. Is this, the early drainage vein needed to be black, dark. Surgical case, where is this AVM? I needed the angiography, I needed to see the angiography before the MRI, because I needed to have in my mind the position of the structures. Where is this AVM? This AVM is located medially to the M2 segment of the MCA. Where is the M2? Where is the parenchyma, the brain structures located medially to the M2? The insular lobe. This is an AVM of the insular lobe. I'm going to pass more fast. So, but to identify the insular lobe, I need to identify why. I need to identify the anterior sylvian point and the superior sylvian point. The insular lobe is located in the deepest part of the sylvian fish. Where is the craniotomy to have the objective to exposure the sylvian fissure? The pterional approach. The Theriano approach is the best approach to expose the insular lobe. So is the surgery. So I am opening the Sylvian fissure, but to identify the veins through, cross the Sylvian fissure, the arteries, no, don't cross, belong, the arteries belong, the frontal lobe, parietal lobe, or temporal lobe. This is a vein. Yes, why the vein? Because it's crossing. Crossing the Sylvian fissure is anatomy. I need to expose the internal carotid, middle cerebral vein, middle, the anterior cerebral artery, middle cerebral artery. I am opening now the posterior part of the Sylvian fissure because I needed to expose the anterior Sylvian point and posterior Sylvian point. Why localize the posterior Sylvian point? The posterior Sylvian point is the rachial gyrus. The rachial gyrus is the same level of the postcentral gyrus. If I see the postcentral gyrus, I know, and below the postcentral gyrus, we can see the postcentral, the rachial gyrus. Why is the insular lobe? The AVM of the insular lobe? Because it's located immediately to the middle cerebral artery. It's anatomy. So to operate this AVM, I need ability, technique. Where I improve my technique? In the lab. The lab is not important so only to knowledge about anatomy. No, it's technique too. It's a very important. I am operating based in anatomy. My surgery is anatomy. I apply the anatomy in all my surgery. All my surgery. All my surgery is the same. In all my pathologies of the insular lobe, for us, the insular lobe cover the basal ganglia. If I have the insular lobe, I have the basal ganglia. If I don't have the insular lobe, I don't have the basal ganglia, correct? So it's a very important. Why is the internal capsule? The internal capsule is located medially to the lentiform nucleus. The external capsule, the fiber is located lateral to the lenticulate nucleus. It's a very important. Why? I go to, I am operating this AVM. Where is located this AVM? This AVM, the angiogram shows feeders from the lateral part of the P2P. The P2P is located in the hippocampus sulcus. The parahippocampus gyrus is located lateral to the PCA. And the midbrain is located medially from the PCA. Where is this AVM? This AVM is located in the hippocampus sulcus. The hippocampus sulcus is located between the dentate gyrus and the parahippocampus gyrus. It's anatomy. Here we see the terminal branch of the PCA and the early drainage vein from the nidus to the Galen vein. The angiogram shows the carotid artery doesn't supply the AVM. Where is located this AVM? In the hippocampus sulcus. This lesion is located in a place with difficult access because of the tentorial shape. The coronal T1 shows that it's impossible to read the lesion by the subtemporal approach because the great repression of the temporal lobe would be needed. We have to remember that the vein lobe is the area of the lateral surface. The sagittal T1 shows the nidus under the pulvinar of the thalamus, and the thalamus, the roof of this lesion. The roof of this lesion. We can see the parahippocampus gyrus and the ankles. The ankles is the anterior part of the parahippocampus gyrus. We can see the P1, P2A, P2P, P3, P4. And when seeing the P2P related with the pulvinar of thalamus. We can see the P-cone, the anterior choroidal artery. And here is the hippocampus sulcus located between the dentate gyrus and the parahippocampus gyrus. And this point where the P2P goes out to the hippocampus sulcus, from the hippocampus sulcus to the calcarine sulcus, pass above the isthmus of the cingulate gyrus. Is the most close point between both PCA. And the best landmark of the posterior fossa is the fourth nerve. When you go in the supracerebellar infratentorial approach, the best landmark is the fourth nerve. Why the fourth nerve? Before the structures located superior to the fourth nerve is quadrigeminal plate, lateral mesencephalic sulcus, the midbrain. The structures located below the fourth nerve, superior cerebellar peduncle, superior medullary velum, interpeduncular sulcus, middle cerebellar peduncle. So the infratentorial supracerebellar approach, I will speak more fast because the time. This is a AVM. I chose the supracerebellar transtentorial approach for this AVM. But this AVM is located in the hippocampus sulcus. But why I reach the hippocampus sulcus? I need to aspirate the cingulate gyrus, the parahippocampus gyrus. I need to aspirate, remove the hippocampus gyrus, identify the fourth nerve. Remember all the time, above the fourth nerve, quadrigeminal plate, lateral mesencephalic sulcus, lateral mesencephalic veins. Midbrain, inferior to the fourth nerve, superior cerebellar peduncle, superior medullary velum, peduncular sulcus, middle cerebellar peduncle. When the fourth nerve touch in the free border of tentorium, anterior, uncus, what I can see anterior, uncus, posterior, parahippocampus gyrus, superior, lateral genicular body. It's anatomy. It's anatomy. It's anatomy. It's anatomy. What's the roof of this surgery? The pulvinar of thalamus. Okay, when we can see the white fibers, here is the pulvinar of thalamus. It's anatomy. Where I can learn it to anatomy? In the lab. The lab is the important for neurosurgeon. If you are a neurosurgeon, we need to go to the lab. It's a very important. It's a very important. It's the post-operative. This AVM of where is the tonsil? The tonsil AVM. We need what's the important in the tonsil is the pica artery. But what part of the pica? What part? The pica, the arteries in the brainstem goes from anterior to posterior. Anterior to the brainstem, the pica anterior to the medulla. Anterior to the medulla, anterior part. The lateral to the medulla, lateral part. Posterior, the cerebellomedullary fissure. Cerebellomedullary fissure. It's a very important. I need what's the tonsil. The tonsil has some freeboards. The medial surface of the tonsil is freeboard. The inferior surface, the posterior part of the superior surface of the tonsil is a freeboard. So the medial surface and the superior surface is related with the pica. I need to know, where is the pica? The pica is in the medial surface of the tonsil. It's anatomy. I needed to remove the tonsil or retract some surgeries. I retract the tonsil only. I can, when I remove or I retract the tonsil, I can communicate the margem D and Luschka. I can communicate margem D and Luschka. It's the inferior part of the roof of the fourth ventricle. The inferior part of the roof of the fourth ventricle. I'm showing more fast. I have just a moment. Oh my God. It's fall. No, okay. It's okay. No. No, that's okay. That's okay. That's okay. That's okay. Sorry. So I'm removing the tonsil. I'm removing the tonsil. So it's a very. I'm removing the AVM. We can see both pica. I can see the floor of the fourth ventricle. When I finish the surgery, when I see the floor of the fourth ventricle. Here, we can see the floor of the fourth ventricle. The end of the surgery. So it's anatomy and technique. Why? I spent a lot of hours to operate this AVM. I needed to rest my hand on the bone. On the bone. So the next case here is the AVM of the thalamus. I pass more fast. The AVM of thalamus. A frontoparietal craniotomy was performed. The superior posterior sulcus is split into two rams, the angular ramus and the occipital ramus. I use the lab technique. I use the lab technique in the sulcus. I put the cotton to dilate the sulcus. The same technique in the anatomy. When I will prepare the specimen, the same. I'm opening the atrium during the CSF. I find the choroidal plexus, which is fixed at 2 points, the tinea fornis and the tinea thalamus. Thalami. Remember, the thalamus is the head of the basal ganglia. Is surrounded by the lateral ventricle. The anterior treated at the head of is the frontal horn. The posterior is the atrium and the occipital horn, and the temporal horn lies below it. If you find the thalamus, you find the fornix. If you find the thalamus and fornix, you will find the choroidal fissure and choroidal plexus between them. If you see the choroidal plexus above the thalamus, you are the body of the lateral ventricle. It's a posterior to the thalamus. You in the atrium. If it's inferior, you are the temporal horn. You can see the choroidal plexus. This is the atrium vein, which drains the AVM. I open the choroidal fissure by moving the choroidal plexus from the fornix. I remove the hematoma to create a space and remove the choroidal plexus. How do I do this? Because I believe the anterior choroid and posterior lateral choroidal arch supply the AVM. We can still see early filling of the draining vein on the ACG. I follow this vein to reach the AVM. I complete the circumferential dissection and they disconnect the vein. The AVM is removed in one piece. The ICG confirmed the disconnection of the shunt. Here is the post-op. I will pass more fast. Post-op the ICG. CT scan, MRI, and ICG. Give me for 5 minutes, please. 5 minutes. I will go through the arterial malformation of the corpus callosum and choroidal fissure. Where is this AVM? This is AVM located inferior to the pericallosal artery. Where is the structure inferior to the pericallosal artery? The corpus callosum. Where the structure located superior to the lateral posterior choroidal artery, the choroidal fissure. This AVM is located in the choroidal fissure and the corpus callosum. I'm speaking more fast. Why is the important point? The foramen of Monroe. The foramen of Monroe corresponds to the brachma. The brachma located between the coronal and the sagittal suture. The brachma is an important landmark because localize the foramen of Monroe. The foramen of Monroe is the superior choroidal point. We have the inferior choroidal point in the temporal lobe, whereas the anterior choroidal artery enter. It's the out is the inferior ventricular vein, and the superior choroidal point is the foramen of Monroe. So here is the choroidal plexus located above the thalamus. The choroidal plexus located between the fornix and the thalamus. The choroidal plexus is here. I needed to open the tinea fornix because I needed to mobilize the choroidal fissure, the choroidal, the fornix. So how do I do? I am showing to open the choroidal fissure is the anatomy, is the technique, because you know about the anatomy. Where is the choroidal fissure? The choroidal plexus is fixed in the fornix and the thalamus. I needed to open. I needed to see the corpus callosum. The corpus callosum is located below or inferior to the pericallosal artery. I am opening the corpus callosum. The corpus callosum is a commissure. The commissure connects two structures, both hemispheres. I am opening. I can see the septum pellucidum. Now I am opening. I am entering the body of the lateral ventricle. We can see the choroidal plexus, medial, fornix, lateral, thalamus. Where I open? I open in the I'm cutting the tinea fornix, but I combine the anatomy and technique. It's a knife inside the ventricle. I am separating the fornix. It's a very important. I am in the, how many structures form the roof of the third ventricle, fornix, superior medullary, superior choroidal membrane, velum interposito, inferior, choroidal membrane. Here we can see the internal cerebral vein, the middle choroidal artery. Here. I am opening. You can see the internal cerebral vein, the middle posterior choroidal plexus. I am opening. I pass the order for finishing. This is a AVM. I have more videos. Sorry, I finished this video. I finished my class. This video is the operative neurosurgery. All my videos is the operative or word neurosurgery. Identify the choroidal plexus. The choroidal plexus is located above the thalamus, and after I can identify the tinea fornis and tinea thalamica. I remove all tinea fornis and tinea thalamica in this case. Why? Because the AVM is located between fornix and thalamus, located in the choroidal fissure. It's applied the anatomy, the technique in the surgery. It's important. The lab is very, very important. I am removing the anterior part of the AVM. Now I am removing the part of the corpus callosum. For me, it's a great honor to participate in this event. I have a lot of videos more, sorry. I have Dr. Kat with inspiration for me. It's Dr. Kat give me a great opportunity in a word neurosurgery. It was a great pleasure for me. She participated of my book. When would you like to do my course? Would you like to come to São Paulo? For me, it's a great pleasure to receive the people from Asia. For me, it's a great honor. Thank you so much for the opportunity.
Thank you very much, Professor, for an excellent lecture, and your compassion to teach the anatomy, especially for the AVM, for the young neurosurgeon, is indeed very commendable. Now, we've got a lot of participants and a lot of guests also. So, but as a protocol, we will go first to the chairperson of today's webinar. May I request Professor Irion to kindly please have 2 comments about Professor Ferris' talk.
I am greatly honored to have the opportunity to speak first, but I must admit I am short of any expectations to get to speak about such a highly passionate vascular surgeon. And it's not only my observation, and I've never had the opportunity to stand next to him when he's performing surgeries, but when we speak and when we get to meet with each other, we realize that there is passion. There is absolute knowledge of anatomy, and that's an interesting fact that you find with those that love to share knowledge, and that's Dr. Ferris. Dr. Ferris, you are among the highly respected vascular surgeon in the community of neurosurgery. It's not for me the time to expand those great words only to you, but as well to Dr. Goel, who happened to attend here with us, to his student Abida Shah. I see this passion shared throughout the world, but not among too many, but those who love anatomy, share knowledge, and you know how to introduce the anatomy to the extent of any young neurosurgeon to understand it and make it to use. AVM surgery has never been easy for me. I do not shy away of the cases, but if I need help, I should be honest, I turn my head and I look, what has Atul Goel done? The reason I started with Atul Goel is very simple, because he's one of our hosts today, but as well another famous vascular surgeon. What has my mentor done, Professor Sana? What has my mentor done, Professor Kato? And when I happened to realize as well the very fame of yours, I said, well, you have to combine those guys together to learn what the vascular surgery, microneurosurgery is for me to learn. And I speak from a standpoint of a former young neurosurgeon in the field. I learned from Professor Kato a great deal. But knowledge is never to the extent of suffice. You have to learn, and you continue. That learning curve is never an end. It is about passion and then practice, practice, practice. I'm going to copy that from you. Practice, practice, practice. It's never enough. Thank you very much for being here today. I will let the field, and if there is the case, not for any of us to challenge you, but for us to open a discussion, and having the opportunity for Dr. Goel to be here. Please join us and do get with your passionate involvement about a topic that stands dear to your heart, and expand that conversation beyond what we as young neurosurgeon love to learn from you guys. So thank you very much, Dr. Ferris, for joining us. I need to remind all of us, by the time that we plan to attend Dr. Ferris lab courses, we should spend some time to watch his videos. There are tons of information. His publications are enormous start for us to learn the anatomy, but as well videos published out there. In recent year, more so due to the pandemic, we've had the opportunity to have a great deal of recordings, and the data is never enough, but we can learn from the masters. Thank you. Thank you for being with us here today, and I open the panel for the rest of the discussants to join.
Thank you. Thank you very much, Dr. Arion. So as you said, without wasting time, we'll go to the expert we have today as our guest to comment for today's talk given by Dr. Ferris, Professor Atul Goel, from whom we've learned the philosophies and principles of AVM surgery. And I would request Professor Atul Goel to give some few tips for the young neurosurgeon, as this webinar is particularly dedicated for the young neurosurgeon, especially from the low resource countries like we have Professor Fawad from Afghanistan, Dr. E from Myanmar. So some tips for the AVM surgery in low resource countries. Professor Atul Goel, please your comment.
Thank you, Sachin. First of all, I must say that this was one of my most beautiful lectures that I have heard during my entire career. What a lecture. You know, what emotions, what passion, what love for the subject, what love for the AVM, love for anatomy, love for teaching. So everything combined, I think this lecture reminded me of my dear friend Evandro Oliveira, who was one of the big exponents of anatomy and AVM surgery. He loved anatomy, he taught anatomy, he did AVM surgery, and combined all these things into one of the most fascinating neurosurgeons of our times. So Dr. Chirad, it was absolutely wonderful. You are so much involved in the lecture. You are so much involved in the anatomy and in the teaching. It made a beautiful experience. After all, I always say that AVM surgery is the last chapter in our subject of neurosurgery. Absolutely, where it is not just anatomy, it is technique, as you rightly said. It is the way to handle bleeding. It is the experience to operate in a bleeding territory, how to handle bleeding from this side, from that side. Sometimes it will bleed from more than one point at the same time, how to handle bleeding and how to go further and to win this war of AVM is not easy. Many of these AVMs can be high flow. Many of these patients, many of these AVMs can bleed furiously during operation, where you have to have all your bearings right, control bleeding, go further. You have to know where is large vessel, what is medium vessel, what is the significance of small vessels. If you ask me, one major trick in AVM surgery is to understand small blood vessels. And when they bleed, you have to follow them to the major blood vessel. It is the, I think, ultimate trick in AVM surgery to follow the small blood vessels that leads to a major vessel, and to control that vessel is important. You don't go on struggling with the small vessel because there is no point in struggling. So AVM surgery is everything but advanced neurosurgery. And if I have to talk to young neurosurgeons who are, as you said, many in the audience, young neurosurgeon has to learn from Dr. Ferris. Number one, the passion and will to learn anatomy, the passion to spend time in the anatomy lab, then to go on, accumulating experience in AVM surgery. AVM surgery is not easy. It is, when you are going to operate on AVM, you can come out with a success, but you can come out with a major disaster. So you don't want to have a disaster because this is not a malignancy. So there is no question that I was very happy to hear this lecture. And it has been an eye-opener for me. Unfortunately, I had never heard Dr. Ferris in the past, but obviously he's an extremely experienced and very popular guy in the field of vascular neurosurgery. And it is my big honor. And I thank you, Sachin. Thank you for giving me this honor. And Yoko Kato is sitting there, and she has given an opportunity to all young neurosurgeons to develop, to progress, to learn neurosurgery, to go further, to have ambitions, to be ambitious, to become the #1 neurosurgeon of the world. The young neurosurgeon who is listening and who is in the audience, he should say, I want to become the #1 neurosurgeon of the world. That kind of ambition will take you to a level further in this subject of neurosurgery. My best wishes to all of you. And Ferris, it was a great pleasure to hear you. Thank you.
Thank you for your words. It's a great honor for me. It's a great honor for me. Thank you so much for your, I am recording these words. Thank you so much. Thank you.
Thank you, Ferris. Thank you.
Thank you very much, Professor Atul Goyal. Every word is alerting for us. May I request Dr. Ibrahim, who's the president of Neurosurgical Association of Bosnia, to make a few comments about Dr. Ferris talk and about the status of AVM surgery in Bosnia.
Thank you, Shahin. Thank you, all of you, for this nice event. We today are witness of beautiful lecture done by Professor Ferris. I am proud to be a part of this evening. So, as the Arion and Professor Goyal said, that was the lecture with so big passion. It's not only about the anatomy and microsurgery of AVM, which is the top of the microneurosurgery, but it's also, something we have to learn from the masters, from the giants, as the Professor Ferris is. Giants say us how the big deal, how the big surgery we can do in easy way. This is most important. And when you see this very easy explained anatomy, which is of paramount importance before you start with the removing or surgery with the excision, it's very important to know where you are and where the AVM is. So before you start with the removing of conus, go in deep to the ependymal top of the AVM, you should recognize all the most important vessels, find the difference between normal anatomy, normal veins and the AVM veins, and but when the master shows you how to play, you get the patient to do the same. And what I learned today is that we should send the message to young neurosurgeons that all of you can be the masters if you learn from the giants. And when if you want to be the good, let me say, best neurosurgeons, you should learn from the best teachers. Then you will learn how to play easy, big deal. So thank you, Professor Ferres. Thank you, Professor Kato, Arion, and Atu, and all of you who organized this. It's very important part. It's Sunday, but it's not lost the time. It's very important to learn this from the masters. Thank you.
Thank you very much, Professor Ibrahim. So after that, may I request Professor Fawad Birzat, who's also the chairperson for today's talk and who's the president of Afghanistan Neurosurgical Society, to kindly make a few comments and tell us something about the status of neurosurgery, about AVM surgery in Afghanistan.
Assalamu alaikum. Namaste. Konnichiwa. Hola. Thank you very much. Thank you, Professor Faris Chadat. As Professor Atul Goel told, it was a brilliant lecture. It was combined anatomy and techniques, and it was very useful for education and practical purpose. And really, we enjoyed your lecture. It was very interesting. Unfortunately, as you know, Dr. Sachin, in Afghanistan, we are faced more with neurotrauma. And just in case of complicated AVM, we face the patient and with the bleeding. Patient come and just we evacuate the bleeding. Unfortunately, there is no chance to do operate on AVM, and I wish sometimes we send some of our young colleagues, young neurosurgeons, for Professor Faris Chadat for training and come back to do some things for our needed people. And thank you very much. Obrigado.
Thank you. Thank you.
Obrigado.
Very much, Professor.
Obrigado. Thank you. Obrigado.
May I request Professor Ferres to tell us more about the training program you're having at your place, so that as I said, that this particular webinar is organized especially for the training of young neurosurgeon and especially for the young neurosurgeon from the low and resource countries. So maybe our colleagues from the Afghanistan or Myanmar, how they can approach to you and how can we help them to do the AVM surgery better. Can you please tell us more about your program, please, Professor?
No, yeah, I can give the people from stay here with me during 1 year. Okay, I can give food. I can give moradia, accommodation. I can give accommodation and I can give food, and they stay in my lab. He participates of my surgeries. Okay, I operate every days. I have 2 AVMs by week, 2 or 3 AVMs by week. Okay, I operate brain aneurysms every week, cavernous malformation, and tumors. But most of the time I operate AVM and brain aneurysm. Okay, it's a pleasure for me to receive people from Asia, from Africa. For me, it's a special people.
Thank you, Professor Ferres, for being generous, for offering to help the young neurosurgeon for training. Professor Fawad Birzat, I will share Professor Ferres' email with you, and then you can have a communication with him and plan your trainees to send there for small short-term training. Thank you. Thank you for Dr. Arian, I can see your hand raised, but I'll quickly come back to you. I'll just take a short comment from Professor Abhita Shah, who's also one of the experts in the, especially in the neuroanatomy. And since today's lecture was about neuroanatomy, I would request her to make a few comments about the anatomical part of the AVM surgery. Professor Abhita Shah.
I would like to congratulate Professor Ferres for this beautiful and wonderful anatomical lecture that he has given, and the correlation of the anatomy with the AVM, to how to decide the location of the AVM depending on where it is located in relation to the vessel on the angiogram, and then correlating it with the cortical and the sulcal landmarks, and then going ahead with the surgery. It is a very important anatomical description that he has given, and is definitely a guide to AVM surgery and also to intraaxial brain surgery. And for all young neurosurgeons, basically anatomy is the key, is the only key to neurosurgery. If you have mastered anatomy, you will be able to operate. As Professor Ferres has said, Professor Goel always says, it is anatomy. And thank you for this amazing lecture.
Thank you so much.
Thank you, Dr. Abhita Shah. Yes, Professor Arian, your hand raised is. You can make your comment.
No, I wanted to join the conversation for two questions we have on the chat. I'm going to try and answer one, but then Dr. Ferres can move forward from the point on. We have Dr. Harshad Parekh. I do apologize if my pronunciation is right, but Dr. Harshad is asking in regard with the extent of the lab work that has been done to Dr. Ferres. And if I'm allowed, I can answer that directly. Dr. Ferres has both cadaveric and simulation options in his lab. And you can see the simulations done throughout the surgeries live in his OR, or you can start the work ahead of time in his lab, because the practice of Dr. Ferres is simple. Practice, do the anatomy, review the case before the surgery, and then during the surgery, simulations focusing. Now, I have session that will help all of us share the contact reference for Dr. Ferres, but at this point in time, and I want to emphasize an important information that goes on with Dr. Pirzad and the needs of all young neurosurgeons. There are options out there to train. But I'm going to copy this. I had this conversation with Dr. Atul Goel, and I'm going to use his words. There are very famous neurosurgeons throughout the world. Limited options exist. I must say limited because not everywhere you can go. But we must, as young neurosurgeons, find those who are humble, able to teach, and have the mastery to offer. The reason I'm copying Dr. Atul Goel came out of a conversation following a conference. It was the World Congress in, I must say, not the last, the one previous. We were discussing and the opportunity to have trainees having trained. And I would highly recommend Dr. Ferres. It's not only because he has passion, but he has the opportunity currently to offer what he mentioned. And that is accommodation, food, and provide you with extensive hours of training hands-on in a lab. It's not only reading papers, having the simulation, but you can do all in one. I visited some places. It's not here the time to make comparisons. Every single place has its own ways of training. But if I'm to go back to the old ways of Dr. Rotten training, you have today in Dr. Ferres' hands a combinations of Rotten school. In addition to that, you have live surgeries with simulation included in the surgery. Now I have the question for Dr. Ferres. It is coming the same from Dr. Harshad, and the question is for the thalamic AVMs. Once you go intraventricular, what technique would you use to avoid compression of the ventricle while you move in and around first, and then as you are pulling out the AVM? Dr. Ferris, that was a question from you coming from the
Okay, for access to the ventricle, for the thalamus, for example, depends of the parts of the thalamus has the AVM, location, the AVM. If it's the pulvinar do thalamus, for example, the pulvinar do thalamus I divided into parts, divided by the fornix. The fornix divide the pulvinar do thalamus, for example, in two parts. The medial part is located in the quadrigeminal system. The lateral part located in the atrium. But depends on the flow of the AVM. Okay, the AVM has participated, the anterior choroidal artery supply this AVM. Okay, the anterior choroidal artery and the posterior lateral supply this AVM. Okay, the brains, the flow, the artery flow goes from inferior to superior. I needed to enter in the lateral. My access needed to be a lateral. In the right side, I use for example, the marginal sulcus of the superior temporal sulcus. I can go to the atrium. The other option, but it's no good to AVM, it's better to the body of the lateral ventricle, is the intraparietal point. Intraparietal point is good for access to the atrium, for example, pathologies, or goes to the pulvinar of the thalamus, but I use for tumors. Intraparietal point, I access for superior to inferior. The other access to the atrium, but it's more difficult because the lateral, I can see the lateral part of the atrium. I have some difficulty to see the lateral part of the atrium, is the interhemispheric transcallosal transchoroidal approach. The other option. I prefer in the pathology of the atrium, I use the lateral, the thalamus, the pulvinar do thalamus. When you belong the atrium, I use the lateral side of lateral surface of the brain. When the middle part of the thalamus, for example, I use the supracerebellar infratentorial approach. Depends of the position and the supply of the AVM or the tumor, for example, I use some approach.
Thank you very much, Professor Ferris. We have Dr. Raja Krishnan Kutty, who's also chairman of our education committee with us. Dr. Raja, you want to make any comment?
Yes, of course. Thank you. Thank you very much, Professor Ferris. We are seeing you for one more time. Previously, you were the speaker for us at the ACNS webinars, and as usual, today is an excellent lecture as well. I was reminded of Professor Lawton's words, which he wrote for 75th anniversary of YNS publication group, that aneurysm surgery is a orchestrated dance which can be choreographed, but AVM surgery is war. So you have today shown that AVM surgery can also be an orchestrated dance which can be choreographed in an excellent manner. The most of the cases you showed were of unruptured AVMs. What about ruptured AVMs where the anatomy is totally disrupted? So do you have a particular path? Do you choose the same path as you go for the unruptured ones, or you look for the preferred approach where if the surfacing hematoma is there or any other important surgical landmarks?
I use
for the ruptured ones to use.
When the eruption, I use the anatomical landmarks. The anatomics for me, I drain the hematoma for gain the space only. I gain the space, but I use the landmarks only in my surgery. I prefer use the landmarks because I look for some landmarks when I plan my surgery. I look for some landmarks to identify my surgery. I apply the anatomy all the time in my surgery. Okay, I have some hematoma. I use this hematoma to gain the space only. I can use it for landmarks, okay, but the AVM is located immediately to the hematoma. That's okay. I know the AVM is located immediately to the hematoma. But for me, I look for all the time some landmarks. The sulci, all the sulci of the lateral in the basal surface point to ventricle. It's an important landmark. But I use the superior frontal sulcus, for example. The direction to the ventricle is very difficult. I can use the neuronavigation, okay, but I can expose the interhemispheric fissure. Why? Why? The corpus callosum is the roof of the lateral ventricle. I know the corpus callosum, the inferior frontal sulcus, is the same level of the corpus callosum. The corpus callosum for up, I don't have basal ganglia. The corpus callosum for down, I have basal ganglia. I use some landmarks in the lateral surface and the medial surface inside the ventricle. For me, the choroidal plexus is the best landmarks. The best landmarks. The posterior fossa, the fourth nerve. The middle fossa, the third nerve. Why the third nerve? Why the internal carotidal artery? Why the uncus? The uncus is an important landmark for us. Why? The uncus cover the amygdala. The posterior part of the uncus cover the head of the hippocampus. The posterior part of the uncus, relation with the posterior cerebral artery. The anterior part, relation with the anterior carotidal artery. Where is for example, I am to perform a PICON and aneurysma surgery. Why am I planning? What's the best craniotomy? The best craniotomy for me in this case is the pterional approach. Why the pterional approach? Because the objective of the pterional approach is the exposure of the sylvian fissure. The sylvian fissure is parallel to the lesser sphenoid ring. The lesser sphenoid ring is the center of the pterional approach. The sylvian fissure is the center of the pterional approach. The internal carotidal artery is the center of the pterional approach. Why? But I can, my view in the PICON is no good. Why too wide this space? I can remove the anterior part of the uncus. Why I can remove of the anterior part of the uncus? Why? Because the anterior part of the uncus is located lateral to the PICON. I can see better the aneurysm of the PICON. I apply the anatomy in my surgery. Why? When I see the AVM, for example, the AVM is located below, inferior to the middle cerebral artery. Where is this AVM? This AVM is located in the uncus or the temporal lobe, but it is located superior to the middle cerebral artery. Where is it located? In the basal ganglia. It's different. Why? When I see, for example, the lenticulostriate artery, the lenticulostriate artery supply the basal ganglia. If I have the lenticulostriate supplying this AVM involves the basal ganglia. I use the anatomy for planning my surgery. I divide the arteries, superficial and deepest artery. The superficial arteries in the supratentorial arteries, the MCA, the ACA, the PCA, the deepest arteries, anterior choroidal artery, posterior medial, posterior lateral choroidal arteries, and the intermediate arteries, the lenticulostriate artery and the thalamus perforating arteries. If you need to embolize the AVM, you need to embolize the deepest part of the AVM. the anterior choroidal artery, the posterior lateral, posterior medial. It's more difficult, okay, but it's the correct, because it's a dynamic disease. If you embolize the superficial part, I divert the flow to the deepest part. I did my surgery. I destroyed my surgery. If the people, I can embolize the superficial part, no embolize. I prefer operate only. It's anatomy and surgery. It's you can all the time. I use my lab for if you look the people here, my fellows is here, for example, are here. My fellows are here. They stay with me all the time. All the time I use anatomy and surgery. They participate of my surgeries. They participate of discussion all the time. All the time. All my surgery, I stop. Oh, what is this? What is this? Why I plan? What if going for this way or this way? It's if I can't to access this part, how I can change the way? I need to have in my mind. But I practice all the time. I have a lot of fellows, I have residents, I discuss with my team all the time. It's very, very important. If you speak and practice all the day, you can get more knowledge. The hematoma is very important. For me, the position of the AVM, and I can gain the space. For example, if I can widely use the natural corridors of the natural corridors, supraoptic, optic, carotid, oculomotor, free border of the tentorium. I can mobilize the internal carotidal artery. But to mobilize the internal carotidal artery, I need, where is the internal carotidal artery? Is fixed. The picon, I can cut the picon. But if I have possible to cut to picon, I need to have the angiogram. It's the fetal, the adult, the normal picon, the hypoplastic picon. I can cut. I can mobilize the internal carotidal artery, but I can mobilize more. I can open the distal dural ring, the second step. I can widely more the carotid oculomotor space. I can mobilize the third nerve. How I do to mobilize the third nerve? I can open the oculomotor triangle, but I can open the oculomotor triangle. I can remove the anterior crinoid process before. After that, I mobilize. I open the third nerve, the oculomotor triangle. I had in my mind all options in my surgery, but I discuss all the time. I practice in my mind for exercise my mind and exercise my hand. The best surgeon will be on Friday, all the time. On Friday, you are your best surgeon. Your hand is very good. Okay, so I look for operate every day. If I don't operate today, for example, it's a deception for me. Okay, it's a deception for me. I love operate. I love anatomy applied to surgery. If I don't apply anatomy in my surgery, for me, it was surgery. It was a very deception for me. So I love my profession. Thank you.
Thank you very much. Sachin, you have to unmute.
Thank you very much, Dr. Raja and Professor Ferris. I can understand the enthusiasm of everyone to have great discussion about this topic. As the topic itself is very interesting, as Professor Atul Goyal rightly said, that ABM is just not about the principles of surgery, it's also about the philosophy. There's a lot of philosophy involved in this particular aspect of neurosurgery, but as protocol of our webinar, we've got 2 speakers today, and we have one more talk to go. And we always have one guest speaker and one YNS speaker. So we have one YNS speaker today. To introduce that, I have my co-moderator, Dr. E, who is a neurosurgeon from Myanmar, and she's specializing in endovascular surgery.
Yes, Dr. E, you can go on as Sachin is disconnected. Please start.
Okay, thank you. Now, next, I would like to introduce one of the YNS member, Dr. Liao. He is from Department of Neurosurgery, Taichung Veteran General Hospital from Taiwan. The topic is retractorless transavient approach for mesial temporal lesion and its complication. So, Dr. Liao, is it your time? Thank you.
Thank you. Thank you for your introduction. And can you see my screen?
Yes.
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 Okay. It's really my honor to have a talk in this ACNS YNS webinar. And after hearing Professor Ferris' talk, let me remind it of the fiber dissection courses. And so today my talk is about retractorless transavient approach for mesio-temporal lobe lesions and its vascular complications. And I have nothing to disclose. And I finished my training in 2015 and from Taipei Veterans General Hospital, Taipei, and I went to Taichung Veterans General Hospital. And today, the talk is about is based on the previous paper I published. It's procedure-related temporal infarction after retractorless transavient selective amygdalohypocampectomy and impact on 2-year epilepsy outcome. And first introduce my mentor, Professor Sanford Su. And I think Professor Ferris and Sanford Su are good friends because Sanford invited many masters to Taiwan, like Professor Yashagyo, Professor Toure for fiber dissection, and Professor Evandro for AVM, Professor Ali Krish for skull-base and vascular courses. And also there are friends like Professor Paulo Kadri and Niklaus Krembo. So from these masters, I learned a lot. And this is the dissection sample I did in the course. So I really learned a lot about the anatomy of mesio-temporal regions. And myself also became a table instructor in a course. So first I share my surgical video to transavient translumen insular approach for hippoparahippocampal GBM. And that's the operation I did in 2018. And this is a left-sided mesio-temporal GBM, hippoparahippocampal gyrus. And this, the coronal cut is bulging upward. And it's a left hippoparahippocampal tumor. And likely a high-grade glioma. In this surgery, I have to avoid damage to the language area, M1 to lenticulostriate artery, and then use the natural corridor to get into the temporal horn because it's left-sided, and avoid damage to the M1-2 and lenticulostriate artery, and avoid damage to the anterior choroidal artery and PCA branches. And because in this surgery, if we damage to the anterior choroidal artery, there may be a leading to the paralysis of the patient. And sorry, and avoid damage to the lentiform nucleus. The amygdala is here, thalamus and parahippocampal gyrus. The boundary is the choroid plexus, and this is the patient position. And first, the start point of the transient dissection is from here, the retracted inferior frontal gyrus. And this is how I do it, just like the teachers taught us. And gently opening the arachnoid membrane. If you use a retractor, it might obstruct your movement. So just use the suction as a mobile retractor to push away the structure and gain more space. I use the blunt dissection and a sharp dissection and inside-out approach to identify the lesion. And here we see the tumor, and I check the relation of the tumor with the MCA branches. Then first do the tumor debulking. And during this approach, the veins are preserved. The normal structures are preserved. And start to debulk the tumor to gain more space. And identify the landmarks, the oculomotor nerves, PCOM, ICA, and remove the tumor at the entorhinal cortex. And now we can see the PCOM, P1, and P2. The anterior choroidal artery. This is near the medial border. And keep debulk. Remove the tumor at the parahippocampus. And because the tumor bulge upwards, so I have to preserve the branches and avoid to damage to the lenticulostriate artery. The tumor near the frontal temporal pole, and use a low power QSA and suction as the dissection tool, and check the lateral margin. And find the choroid plexus. Just like Professor Ferris just mentioned, we need to identify the normal structures in the surgery. It helps us to avoid disorientation and make sure that we get what we want. So this is the last piece of the tumor near the anterior perforate substance and lentiform nucleus. See the small branches, lenticulostriate artery. You have to avoid damage to these arteries and gradually remove the tumor. And check the superior margin. And put some hemostatic agents. And this is the final view of the operation. So we don't need a rigid retraction system to hold the brain, because our instrument can be a dynamic retractor. And this is the post-op view. And the patient had no new neurologic deficits. So Transilvan approach is a good approach to the messiotemporal lesion. In addition to the supracerebellar transtentorial approach. And the Transilvan approach was developed and populated by Professor Yashagil in 1982. Since then, this approach has been utilized. And my mentor, Sanford Su, and Professor Cranbo also rejuvenate this approach and published the paper in 2010 and with Professor Yashagil. And during my training period, I learned this approach also, but just in the lab to know the anatomy. And at the time, I myself really did this approach. I find some papers in the literature, and it mentioned about the Transilvan approach and its related temporal lobe infarction. And I will discuss it in the later part. So I did some research about this problem. And from 2010 to 2014, there are 30 patients receiving the selective amygdalohypocampectomy in Taipei Veteran General Hospital due to the seizure, the epilepsy, messiotemporal sclerosis. And the MR was performed first week and 6 months after the operation, and neuropsych and angle classification, a 2-year outcome was also analyzed, and weighs third edition as to the IQ test. And because I'm not really mastering this technique, so the following surgery for the messiotemporal sclerosis, the SAH, is performed by my previous senior colleague, Dr. Chen Fu Lin. And we can see that. And this approach spares the Meyer's loop. And so it causes lesser damage to the optic radiation and to avoid the visual impairment. And it directly get into the temporal horn. And as I just mentioned, we did the Transilvan approach from the this point, the anterior Sylvan point, because there's a larger space here. This is a frontal, temporal, and use either sharp and blunt dissection. I myself did a couple of cases of SHH for the mesial-temporal sclerosis, and I still find it difficult to have the en bloc resection of the hippocampus. And my senior colleague, Chen Fu Lin, did it very well. So I share this video with you. And preserve the vein also, and identify the M12 and lemon insula. We just made a small incision lateral to the M12 junction. And as mentioned in Professor Yashagio's paper, we put a soft carotenoid to gain some space. A small incision was made at the lemma insula, right over the amygdala. This is a transamygdala root. And we can see that now this is the temporal horn. We enter the temporal horn more anteriorly to avoid injury to the Mayer's loop. And we can see this whitish structure. This is the hippocampus. Now the choroid plexus. This is the landmark we need, because then there's the anterior choroidal point where the anterior choroidal artery enters. We have to avoid damage to it. And as a routine, we put some a grid before resection. It's just some research. And we find the lateral border, the collateral eminence. And use the subpial dissection to remove the tissue. And now the medial border is the choroidal fissure, the choroidal plexus, and this is the inferior choroidal point, excuse me. And avoid damage to the anterior choroidal artery. And keep the subpial dissection to remove the pes of hippocampus. And we keep the arachnoid membrane intact. And cut the arterial supply to the hippocampus. We have to identify clearly before we cut the artery. We have to make sure that it goes into the hippocampal sulcus and supplying the hippocampus, then we can cut it. The anterior border is the uncus, anterior and medial side. And dissect the hippocampal sulcus. This is the more difficult part, because most of the time here is is difficult to dissect, and you have to use your surgical technique. And then we cut the hippocampus at the tail. Sometimes we can use the CUSA to extend the exsection, more of the tail can be removed. So this is the en bloc remove of the hippocampus. It's almost 4 centimeters long. Additional removal at the tail, and post-op EKG recording, and this is the post-op view. So this is the retractless approach. And immediate post-MRI showed that there's some perisurgical cavity small infarct, but it's understandable because it's just at the surgical cavity. So this is the surgery. We can compare the post-op MR. The left side is the normal side. The right side is the post-op, immediate post-op. So we can compare the normal and the resection cavity. So slice by slice, the coronal cut, the axial cut. So in this approach, we can remove the hippo and parahippocampus to the tail, way beyond the cerebral peduncle. And in the immediate post-op MR, we can find there's some changes along the resection cavity and maybe further. And this is some insular infarction at the insular cortex, the DWI, the ADC series. So I reviewed all the patients' immediate post-MR and measure the size of infarction. And total 30 patients, 13 are male and 17 female. This is the characteristics of the patients. And I use the PEX system to measure the size. And the removal size, the average removal size is about 5.7 cc. And the infarction size there are 27 patients have post-op infarction. The average size is about 1.7 cc. In 2 cases, we have vasospasm. It's about 6.7%. And these 2 have a larger infarction size. One is 16A cc, is a right side, and anterior temporal region is asymptomatic, and the other is 5 cc, left middle temporal region. The patient had a transient aphasia. And in 15 patients, there are 0.25 cc of insular infarction. And in this patient, one need a VP shunt, one had asymptomatic cerebellar hemorrhage. And this is the neuropsych, previous pre-op and post-op. We can see that the perceptual organization index got improved after the surgery, and the episodic memory, the verbal paired associates to also improved after the surgery. So I did the statistical analysis and found that neither removal nor infarction size is related to the outcome. These all the patients' data, the estimated removal volume and total infarction volume. The 2-year seizure outcomes are good. About 83.3 are Engel class 1. And let's move to the discussion. Does the removal size matter, or procedure-related infarction size, self-retaining retractors or not, and the verbal IQ and memory? I did this research because I, in my training period, I read some paper, and this is the one that the title is Vascular Events After Transylvian Selective Amygdalohypocampectomy and Impact on Epilepsy Outcome. This is performed by our German colleagues. It's from 2008 to 2011, total 54 cases, and 9 are tumors. And in their study, they got a larger infarction, about 48% in temporal, and the infarction size is about 3.19 cc, and the frontal infarction 10%, 0.73. cc. And they got the result of angle class 1 is 69%. And they have the conclusion that more temporal infarction had a better, is associated with a better seizure outcome. And the temporal infarction in dominant hemisphere is associated with verbal memory deterioration. But this, so this is their conclusion. Unintentionally eliminated volume due to infarctions had better seizure outcome, and the anterior temporal lobectomy is a favorable procedure compared to SAH, especially in non-dominant hemisphere. Because of this paper I read on epilepsy, it confused me, so I did my own paper and analyze the outcome. So I think because their surgical approach, they use a rigid retractor system. So maybe I think that's why they got more infarction volume. So does removal size matter? During this period, I split it into a previous half and posterior half of the patient group and analyze it. In the previous 15 patients, the average removal size is about 4.9. And at the later period, with more experience, the removal volume is more, is going to 6.5 cc. But actually, in the statistical analysis, there's no real difference between the removal volume. So our study compared with that of our German colleagues, maybe the procedure-related infarction size is it occurred more if you use self-retaining retractors. And actually, when you use a retractorless Transylvanian approach for SAH, you can have improved verbal IQ and memory. The limitations of my study is a small number of patients, and maybe there's some measurement bias of the removal or infarction sizes. And just like Professor Ferris just said, anatomy is really important, but the Transylvanian approach also has its limitation when you get into the messiotemporal region. It sacrifices some fibers in this approach. So if you want to purely remove the amygdala and hippocampus, you can choose the paramedian supracerebellar transtentorial approach. And it's but as for me, I haven't had the experience to do this, and I'm still learning. And the take-home message is that retractorless Transylvanian SAH cause less temporal infarction and no frontal infarction, and post-op POI and VPA2 improved. And neither removal nor infarction size is related to outcomes. Is my talk. Thank you.
Thank you very much, Dr. Liao, for a fantastic lecture, and I congratulate you for taking up this particular approach ahead and taking up a very good data and literature review. And as you mentioned in your discussion slide, we'll take those discussion points ahead and go with the discussion that the tips and nuances of this particular approach when it comes to messiotemporal lesion. What is the tips and nuances of Transylvanian approach, especially the retractorless approach? Does the tumor size removal matter? And how about the procedure-related infarction? So with those points, I would request Dr. Arian, kindly please make your comments about Dr. Liao's presentation and this point of discussion.
Kindly unmute, Professor.
You're not audible, Dr. Leo.
Can you hear me? How about now?
Yes,
Can
we
you hear
can
me
hear.
better?
Yeah,
My
we can hear you
apologies.
now.
My
Yes,
apologies. Let's go back. Dr. Liao, thank you very much for your honest presentation. It stands out. You laid down the way you find it challenging and how you proceeded to conducting with the research. More often than not, when we attend lectures abroad, it's about success. But I think to learn, and especially for young neurosurgeons, is to show how the curve of learning came about. I do commend you for talking about the paramedian supracerebellar transtentorial approach, whom you mentioned very nicely on your talk. And yes, it is challenging to get into it. I would encourage, if possible, to consider brachiocephalic head type for you to start first on that approach. It mentioned on the first paper of Dr. Touré, when he studied the anatomy and used the very same approach to conduct total removal of that area, parahippocampus, from that approach. Now, retractyless, I love it. I try to use it as often as I can, or minimize the time that I have to use a retractor. I come from a school where retraction is basic, but I never liked it. So your technique using a sector and dissector rather than the retractor is admirable. I do know and have read papers just like you shared, being out there, showing us that there is still infarction. I am not able to tell why is that when we don't use a retractor, we are still able to observe and publish that there is infarction. But the only reason I can make a connection to the point in the presence of infarction is the anatomy landmarks that we have to come across, we have to coagulate, and the anatomy landmarks that we have to cut off from the area that we have to remove. That's the only way I can come about the presence of the infarction. And I want to make the comparison of the papers and your work. The German, the papers that published by the German colleagues uses retractor. They still have a presence of infarction. So not necessarily related to retraction, one should say when conducting research. But with that, I will cut it short because I don't want to take time from the rest of colleagues. Wonderful work, and I very much would love to see the next steps of your learning curve using paramedian transtentorial approach. Thank you so very much.
Thank you.
Thank you very much, Dr. Irion. May I request Dr. Ibrahim to make a few comments and tell us about your experience of this particular approach?
Thank you, Shahin. Just few words. Nice work. Dr. Rao showed us very nice surgery. Good to see how he opens the Sylvian fissure. It's not so easy as the people mean sometimes, especially if you have the space occupating lesion inside. So sometimes the frontal and temporal lobe are very tight connection, and it's tough to open the Sylvian fissure, go inside to temporomesial region. And sometimes, yes, we can use this approach also for the epilepsy surgery, for temporomesial sclerosis also, as and also those techniques which was described mostly by Professor Uğur Ture from Turkey. Those supratentorial approach is very nice actually approach. So I use it often for different lesions, different locations. And for the beginning of the neurosurgical career, it looks too strange and a big challenge to go through and through the tentorium or fast cerebri or open the skull close to sinuses, venous sinuses. However, if you have your anatomy in your brain and also use the gravitation, where you position the patient in good position, for example, semi-sitting position or lateral, contralateral approach through the falx or tentorium, you actually, gravitation help you to get enough space to approach to temporomesial or amygdalo hippocampal region, and this is very nice approach. I think so that young neurosurgeons start to learn about that much more than we usually see they use it. So very nice. Congrats, colleague Laio. And for all of us, suggestion, don't be far from this different approach than we usually learned 20 years ago. Mostly it was the frontal anterior approach to amygdala hippocampal region, but recently many of masters use this posterior approach, transtentorial approach, transfalcine approach, for example. Sometimes if I have the lesion in this region on the left side, I'm going through the right side to the falx cerebri and tentorium, and then I make the incision on the falx or tentorium, make a fenestration, and then remove the lesion on the contralateral side. Also, when I have some AVM which are on the both sides in this region, sometimes I'm using transtentorial and transfalcine approach from both sides. So don't have a fear from this approach. It's very nice, and we have enough space, especially when if we count to gravitation also. Thank you.
Thank you. Thank you very much, Dr. Ibrahim. Very nice to have you. As I can see, Dr. Arian, your hand raises. Then you want to make any point, Professor?
Just want to add something to Ibrahim's talk. I do apologize for missing this point. Sitting.
Your voice, your microphone speaker.
Yes. How about now better?
Yeah.
My apologies. I'm so sorry. I want to add to the voice of Ibrahim in the positioning of the patient. It is daunting and challenging when using the sitting approach for transtentorial, supracerebellar. There are complications related with the sitting positions. You would really need a good anesthesiologist, not only that, but a good team to come around with you. So with Dr. Lawton, we are working on a paper to have it published. We use the lateral position. There is nothing of extra work done. We don't see any difference in the opening space. The channel remains the same. The width hasn't changed. And yes, if you do not invade the anatomy, you would have the gravity help you pull down nicely the cerebellum somehow, open wide that corridor that you are going to have to use to access any part of temporal lobe. And as Professor Touré echoed the voice of Yashar Gil, is that from this posterior approach, you can have access all the way without having to transgress the temporal lobe or having to use retractors all the way, not only to parahippocampus, but to hippocampus. And he has published work without any complications. So thank you, Ibrahim, for bringing out the point of having the patient positions. We talk about the approach, but how we do have the patient sit, I don't use sitting. Well, actually, I've never done it in a sitting position. Thanks.
Okay. If I may say
yes,
something.
Please go. Yes, yes.
Thank you, Shahin. Yeah, thank you, Elion, to remind me for the lateral position. Also, I didn't mention that. So when I use the lateral position, for example, for this region, if the tentorium is too much vertical, so sometimes when we have the semi-horizontal tentorium, it's fine to go supracerebellar, transtentorial, or infratentorial, and so. But when you have the too vertical tentorium, sometimes it's impossible to go supratentorially even on the beginning of the surgery. So you cannot be close to the hippocampal region, but you have to cut the tentorium very early on the beginning of the surgery. So at this situation, I prefer lateral position. I agree. Thank you for that. Thank you for mentioning that, Irion. And also, yes, semi-sitting position or sitting position, the main reason why neurosurgeons say that is the dangers of thromboembolism. So if you are trying to do the sitting position, you have to have the very experienced anesthesiologist to be prepared to solve the problem with embolism. And another thing, it's very important for me also, it's that you're mostly doing not in sitting but staying position for neurosurgeon take you energy, and I am usually much more tired after the surgery in the sitting position than in lateral position or supine. However, it's up to neurosurgeons to choose the approach which is the most appropriate for him and for patient on the first place. Thank you.
Thank you. Thank you very much, Professor, for bringing out that topic, which is especially very important indeed for the young neurosurgeon. Sitting, or especially the position of the patient, is absolutely very important. So may I request Professor Ferez Chadat, if it's there, when it comes to a mesial temporal lesion, I'm sure you must have had mesial temporal AVMs, wherein you preferred this particular approach, or what was your approach strategy in case of middle temporal AVMs? And if you could make a few comments about Professor Lau's presentation.
Yeah, depends on the part of the middle temporal lobe. Depends of the part, sorry. If the posterior part of the middle temporal lobe in the left side, I prefer the supracerebellar transtentorial approach, okay? Or infratentorial or transtentorial, but supracerebellar approach. I use all my case. I have some exceptions, okay? The communication between atrium of the heart. I use the semi-sitting position. I have a good experience with the semi-sitting position. I don't have problem. My anesthesiologist, it's a very experienced in my team, and very experienced in the, have a good experience in semi-sitting position. I open the patient, I operate the same position that I use in the lab, the same position, okay? How I dissect the head, the posterior fossa, for example, the middle temporal lobe, in the midline, okay? A long time ago, I moved the head. Now I don't move more. I move my chair, okay? I move my position, because the position of the muscle, the position of the cerebellum, the brainstem, the middle temporal lobe is the same of the dissecting the lab. Okay, the posterior part, I prefer use the supracerebellar transtentorial approach. I use sometimes I use the Yassar-Gil, the Professor Yassar-Gil approach, the Transylvian inferior circular limitantly sulcus of the insula to reach the middle temporal lobe. I can use. I don't use for epilepsy surgery. We use it for epilepsy surgery a long time in the Unicamp. I and Dr. Evandro operated a lot of cases of the middle hippocampectomy, but the result were not good. Why? Because this patient has a particular. The vessels is enter in vasospasm because the drugs, the antiepileptic drugs. So I prefer in this case the middle temporal gyrus, the Niemeyer technique. The result is better for this case, okay? But the anterior portion of the medial and the posterior portion of the cingulated, the hippocampus gyrus, in the left side, I use the supracerebellar or transtentorial approach. In the right side, no dominant lobe, I can use the subtemporal approach. It's possible to use the subtemporal approach, Why? I put my retractor in the collateral sulcus. I can reach the inferior temporal horn. I can reach the all middle temporal lobe. Okay, I can reach this part. When I have pathologies of the anterior part of the ankles, I use the pteronal approach. When I have the other approach, ankles and the parahippocampus gyrus, I can go the anterior to posterior. I can use the OZ approach. The OZ approach, you can use the OZ approach to the median lesion, the lesion in the medial temporal lobe. Why? You go to anterior to posterior. Okay, it's good. I have some cases if the cavernous malformation, I use the OZ approach to remove the pathologies of the middle temporal lobe. Okay, but most of the case, I can use inferior limitant sulcus, the Sergio techniques, to reach the temporal horn and the middle temporal lobe. In the posterior part, in the eloquent area, I use the supracerebellar infratentorial approach. But in all the cases, in this, I use the same sitting position. For me, it's the best position to infratentorial, supracerebellar, or transtentorial approach.
Thank you very much, Professor. Anybody has any comments or any doubt or any question for Dr. Lau or Dr. Chen? What happened? You raised your hand and yes, you want to ask anything?
Congratulations, yes. Sorry. Congratulations for the presentation. We feel very good presentation. Congratulations. Congratulations.
Thank you.
Sandorf was very good, friend me.
Yeah. Sorry, I didn't find the picture.
Very good. Send a hug for
Sure.
Yes, Dr. Chen, you're saying something?
Yes. It's very nice presentation. For the insular tumor resection operation is always a challenge to a young neurosurgeon. And I'm thinking, would you like use a DTI technique before the operation to plan the process, or would you like think about intra-operation awake technique? In operation, you can protect the neural function and how to avoid to hurt the small vessel arteriole and do not push the resection too deep. That's my question. Thank you so much.
The question for me or for Professor Ferris?
Both.
Okay, maybe I can. As to your question, because this is a messiotemporal lobe lesion, it's not an insular lesion, so there are different. So in this procedure, I don't use awake surgery. I don't use, there's no need for the DTI reconstructed tractography. And just if you want to use some assistant, you can use the navigation to lead you to the temporal horn. So I think it's very different. Insular tumor and messiotemporal lesion are different, and it's my answer. Thank you.
Okay, thank you.
Thank you, Dr. Lau.
And I have another question for Dr. Chadat first.
Yeah, I'm here.
Yeah, I love your presentation so much. With so full of passion. Your passion makes us feel impressive, and we can remember the anatomy so deeply in my mind. Yeah, and I want to help my friend. He is working in Kenya, in Africa. He is looking for a program can accept a young neurosurgeon for training. So how to apply the training opportunity for him?
Yeah, send me an email. Send me an email.
Email, where can I find your email?
Yeah, Ferry Shaddad.
Can you tap on the board? Yeah?
I will post my email. I will post my email. Okay? Please send my email. It will be a pleasure to receive your friend. Okay?
Thank you so much.
Receive your friend. Your friend. It will be a pleasure to receive your friend. Thank you.
Okay. Thank you. And you are talking about you practice in the lab every day. It's amazing, really. And how can you keep your life between the lab practice and daily surgical time?
Como é que você consegue praticar todos os dias?
We are lab. It's open all the time. Okay, the people that stay with me go there all the time. No, all the time. Okay, I don't have surgery before surgery or after surgery. I use the lab. The lab I can use for give you a speech, for give you a class, for planning the surgery, and for dissect. When I was a resident, I went to the lab all the day too. During the lunch, I stayed in the lab. The lab needed to be a part of your body. Operating room needed to be a part of your body. Your mind. If you have a breakfast, a lunch, a dinner every day, you need to pass there. Okay, I don't dissect, but I need to go there. I stay there 10 minutes, 30 minutes, 1 hour, 2 hours. But important, you have a contact with the brain, with the placenta, with the head, with the cavernous sinus. I have a school in my table, in my home. Why? I look. Oh, yeah, I look all the time. I look at the school. I have in my skull. I have the skull in my home. I look the relation with the anterior clinoid process, with the lesser sphenoid wing, the anterior, middle, and posterior clinoid process. Is very important to look. And you move the skull. You move, give a position of the head. When I use the OZ approach, for example, I have some points to use, some pathology, some places to use the OZ approach. When I extension the head, when I put the malar eminence in the top, the lesser sphenoid wing in the top, the Sylvian fissure in the top, the middle cerebral artery in the top. When I move the skull, I put the M1 deep part. I have problem to dissect the M1. When you move your skull in your home, you had give you a position of the head, the position of the arteries. When I see the lesser sphenoid wing, for example, I see the middle cerebral artery. When I see what's represented, the anterior clinoid process is a good landmark for us. Why? Because it's the medial extremity of the lesser sphenoid wing. It's the lateral wall of the optic nerve. It's the roof of the superior orbital fissure. is the anterior part of the roof of the cavernous sinus. Give me a lot of landmarks. Why I identify the anterior clinoid process in my surgery? I see the optic nerve, the lateral structure of the optic nerve is the anterior clinoid process. Why identify the anterior clinoid process, for example, in extradural? The meningoorbital artery. When the meningoorbital artery enters in the lateral part of the superior orbital fissure, I know lateral lesser sphenoid wing, medial anterior clinoid process. Because it's very important, you see the skull all days, in 5 minutes, 10 minutes. You create your own lab. It's a very important. You frequent the lab all the day. You go to the coffee, you go to the hospital, pass in the lab. It's very important. Dr. Houghton passed it 30 minutes all the day, every day. 30 minutes only. 30 minutes in the counting the watch. 30 minutes. 10, 10, 30. From 10, 10, 30. Okay. But in 30 minutes, we have a contact with all parts, all structures in the brain. It's very important. Oh, I stay 15 minutes, 10 minutes, but it's important you go to the lab.
Thank you very much, Professor. Ben, I can see your hand raised. You want to make any comments?
Yes, thank you, Surgeon. I'm Ben, one of the young neurosurgeons from Hong Kong, and I would like to thank you, Professor first, and Professor Liu for their presentation. It's one of the best inspiring and passionate lectures about neuroanatomy, and I will watch it again for this wonderful seminars. And I don't have any question, but a few comments. Is the things I learned during my journey of training in neurosurgery is the neuroanatomy is a very important aspect for all neurosurgical operations, and also the practicing in your lab and also at home is very important in my daily lives of training. And I would like to echo with Professor First and Professor Liu's opinion on that. And it's also very amazing to see how neurosurgery brings us together so that I could listen to your lectures. And also, for example, I also learned from my Professor Stanford Shield I have chance to learn something from him. And also, for example, Professor Wen, also from Taiwan. It's so nice to see different peoples all together to learn together. And the only things I would like to request for Professor First and Professor Liu is that, is it possible that they will share your contact, and also how about how could I get updates for different courses organized in your laboratory so that I could pay a visit after the COVID. I'm okay to pay my accommodation and food myself, and I hope to learn from all of you after the pandemic. Thank you so much, and also thank you, Sachin and Professor Yokato, for organizing this great webinar.
I have my Instagram, @Ferdshaddad.
Okay.
I send all the courses the next month. Start by my courses in São Paulo. We have courses in May, June, August, September, October. It's a pleasure.
Thank you so much.
Visit us.
Thank you very much, Dr. Bain, for active participation. I'll share the contact
also
numbers.
Professor Liu, your lab.
Yes.
Yes, I will type it in the question and answer there.
Thank you so much.
Thank you very much, Ben. I'll share the email address of both the speakers with you. and
so
you can contact them and schedule your fellowship. Thank you. Thank you very much for active participation. May I request Dr. Fawad Pirzad to make a few comments about Dr. Liao's presentation about the Trans-Sylvian approach and your experience about this particular approach, Professor.
Okay, thank you, Professor Liu, Li, Ho, and Tusia. Thank you. It was a nice presentation. Thank you very much. It's good, but I like to mention that this sometimes not clear that the infarction belongs to retractor or it belongs to the lesion that's be removed. But it was excellent presentation. Thank you, and good research. But it needs more research and doing work on it. But after retractor, sometimes it's not for me also to do operation. But it's good. Thank you very much.
You're welcome. Thank you.
Thank you. Thank you very much. I have a last question for Dr. Liao. So the beauty of retraction is you get a good space and there is a comfort when you are working and you are not handling the vessels too much. But at the same time, the retraction causes retraction injuries, that is in the form of contusion or sometimes infarction. Infarction also happens when you are doing retraction-less surgeries because you are constantly moving your retractor and that is causing vasospasm. So like whatever literature review and your experience you've done, what do you think, where is the vasospasm related injury more, in case of retraction or in case of retraction-less surgeries?
I think the most important is reduce the manipulation of the vessel, because sometimes some patients' vessel are very sensitive. When you touch it, you will obviously see that it contracts and vessels have vasospasm. So I think reduce the manipulation is the most important part. Yes.
How about using some sort of papaverine or nimodipine intraoperatively to prevent the vasospasm? What is your opinion about that?
No, if you observe the vasospasm, you can use papaverine, but there's no preventive usage, I think.
Thank you. Thank you.
Thank
Thank you very much,
point,
Professor.
yeah. Sachin,
yes,
I just wanted to add.
You want to say something? Yes, yes, please.
A wonderful point. There is no help using any of the calcium channel blockers in advance because they do not operate on non-active channels. So yes, I would echo it that use in advance would not help, but minimizing the retraction and just using the set of tools that you have in your hands without having the need of retraction gets enough space to get to where you want. But I want to echo just one point from Professor Ferris. If you know the anatomy of where you are going in advance, it helps you to come along your vessels that would lead you directly to the lesion, or to whatever the lesion is. It doesn't necessarily mean to have a dysplastic lesion or a tumor. It can even be the vascular lesion by all means. So thanks, Sachin, for the question that you brought up. Thank you.
Thank you very much.
Your comment is very good. Your comment is very good.
Thank you. Thank you very much. Thank you. Thank you. I would prefer an assistant who is giving me a dynamic retraction than having a constant retraction. That's how I've been trained, and I was assisting my professors. So, is there any other question or doubt from anybody? If not,
Dr. Sachin, maybe Dr.
Yes.
E from Myanmar.
Dr. E had to.
Some question.
Dr. E had to leave for one surgery, so she's not there with us. Yes.
Sachin, you shared your experience with your mentor. I want to share mine with my mentor. Back home in Albania, I remember our senior neurosurgeon, and when I say senior, we had only one. I don't know for what reason there's only one senior neurosurgeon, but he would always use retraction. It doesn't matter where. He would always use retraction. He admired the work of Yashar Jil, but I guess it was only by showing that he admired. He never practiced Yashar Jil work in his surgeries. Using retractors, I have seen whatever complication there might be in neurosurgery, and I've learned from that why not to use retraction. That's simple. That's how I learned. Would I have done the same? Yes, if I had to follow the same path. But thank God I did not have to learn from my mistakes. I learned from others, and that was a wonderful lesson. I do not like to use retractors, and I've seen it throughout my training. I'm not saying my practice. It's small to compare with what I've trained of. So thank you.
Thank you. Thank you very much, Professor, for the comment. Anybody has any questions? So we started at 4 o'clock. It's almost 6:40 in India, almost 2 hours, 45 minutes. It was a wonderful session today. May I request Professor Yoko Kato to say a few comments and about today's webinar and some words for the young neurosurgeons.
Yeah, I think for this is a webinar for young neurosurgeons, and we should have a longer maybe webinar, but some restriction of time for senior doctors, so we need to finish. But I want to thank you very much, especially Dr. Arian and Ibrahim. So Arian is one of the my best fellow. Now he's working in Canada, and his work is very precise. So I very much admire his attitude to the research or clinical work, I think. And also the Ibrahim, of course, I know him since many years before, and he can be one of the leader in the Balkan Peninsula, I think. So he has so many responsibility to teach the young doctors, those regions, I think. Some area is still need more, I think, training and also the teaching, I think. And people from Afghanistan, maybe I think your country, I think we need the more special training, and also from the beginning, maybe. So maybe that you can suggest your young doctors to go to the Ferris place or somewhere for very basic training, I think. That's very important. And as ACN Congress, maybe we can share some video or the young doctors can see those videos, repeat. I think they can have more knowledge. So as a whole, the Ferris, the lecture was of course the excellent. And I think AVM is not so many cases. I think just 1/10 of the aneurysm cases. So it's kind of very rare, the disease pathology, I think. There's so many the problems to be solved, I think. But recently, as in Japan, we focus on especially the elegant lesion and also the large size of the AVM. So how we can treat them in addition of the radiosurgery. So we should be research the more and more. And also maybe I think some of course the Ferris techniques and also anatomical points is most fundamental, very important things. And in the future, some drugs or some another methodology will come up, I think. So we learned the more for AVM, but anyway, the very good lecture for YNS, especially Brazil is very famous. The late Dr. Atos, that he was one of the pioneer of the AVM surgery. Thank you very much. So you can involve more Asian education in the future. And also, Dr. Liao from Taiwan. Thank you very much. Already, Dr. Ferris, he mentioned your presentation was perfect. 200% perfect, I think. Very good presentation with your papers. And I think what is your next next goal or the next the research? I want to hear maybe by email something.
Okay, thank you.
Yes, you can tell me.
I'm still struggling.
Okay, so the veteran hospital is one of the best neurosurgical center in Taiwan. I know since many years before. Dr. Shi already, she passed away, and maybe your boss is a son of the Shi, I think. So that your circumstances very nice the people, and also your teachers very good, excellent teachers, and the mentor you had. You're very lucky, and I think maybe these the lectures are good for YNS, and maybe you can contact with lecturer today, I think, in the future. So sorry, so Dr. E already she left. I think we'll finish this YNS webinar maybe within 2 hours.
Yes, we'll do that next time.
It's quite long, but I think it's a very good organization by Dr. Sachin and Dr. Liu as always. And also that Dr. Ben is always assisted our webinars. Thank you very much. So in Japan, maybe have a good night. And also some of you will start the work. Dr. Ferris, Ferris, please, and also Ibrahim. So maybe you can involve more and more educational activity. Thank you very much for your joining today. Thank you very much.
Thank you for